Hello everybody, good morning and welcome to our YouTube channel. In this channel today we are going to start a new series of video related to midwifery and obstetrical nursing. And in this series the first topic that we are going to discuss today is postpartum hemorrhage. Now this postpartum hemorrhage, if you see, is made up of three words, that is postpartum and hemorrhage. So post means after, partum means delivery, and hemorrhage means bleeding. So in general terms, postpartum hemorrhage means bleeding after the delivery of what? Delivery of the baby. So this postpartum hemorrhage is actually a very rare condition which we see in women, which is characterized by vaginal bleeding. Then moving on to the definition, postpartum hemorrhage is actually a condition in which there is excessive amount of bleeding from vaginal tract which occurs immediately after the delivery of the baby, or which may occur at any time up to the 6 weeks period after the delivery of the baby. So generally we see there will be bleeding during the delivery process. So do we call it as postpartum hemorrhage? No. Postpartum hemorrhage, we call a bleeding as postpartum hemorrhage if it is equal to or more than 500 ml. So this postpartum hemorrhage is actually a very rare complication seen in the third stage of the labor. And when we talk about incidence of the postpartum hemorrhage, it is 4 to 6% seen in all the pregnancies. Then talking about classification, this postpartum hemorrhage is actually classified into two types, that is primary postpartum hemorrhage and secondary postpartum hemorrhage. And again in turn, this primary postpartum hemorrhage is classified into two types, that is true postpartum hemorrhage, or we call it as true postpartum bleeding, and third stage postpartum hemorrhage or third stage bleeding. So now let us discuss in detail about primary postpartum hemorrhage. So we say the bleeding as primary postpartum hemorrhage when this bleeding occurs within the 24 hours of the delivery of the baby. That is, once the baby is delivered, from the point of the delivery up to the next to 24 hours, if there is any bleeding seen, we call it as primary postpartum hemorrhage. Now, if you might have observed in the stages of labor, in third stage of the labor, there is expulsion of the placenta due to strong uterine contraction, right? So due to the strong uterine contraction, the placenta which is inside the uterus is naturally expelled out of the vagina. So based on the expulsion of the placenta and time of bleeding, this primary postpartum hemorrhage is again classified into two types, that is true postpartum hemorrhage and third stage postpartum hemorrhage. If the bleeding occurs before the expulsion of the placenta, that is placenta is not expelled out yet, it is still inside the uterus, but there is excessive amount of bleeding from the vagina, then that condition we call it as third stage bleeding or third stage of postpartum hemorrhage. If the bleeding occurs after the expulsion of the placenta, that is the placenta is completely expelled out but still the bleeding has not stopped, it is continuing and it is in excessive amount, we call it as true postpartum hemorrhage that occurs after the expulsion of the placenta. Now talking about the etiology, that is causes of the primary postpartum hemorrhage, the simple thing you have to do is you have to remember 4 T's of postpartum hemorrhage, that is tone, tissue, trauma and thrombin. That is tone, tissue, trauma and thrombin. So in tone refers to atonicity of the uterus, that is the uterus is unable to induce contractions. Atonicity of the uterus is a condition where the uterus fails to generate uterine contractions. So this atonicity of the uterus may be directly or indirectly caused due to certain factors such as grand multipara, over distension of the uterus, antepartum hemorrhage, prolonged labor, augmentation of labor by oxytocin, malformation of the uterus, uterine fibroids, precipitate labor, and mismanaged third stage of labor. Now, see, grand multipara women are those women who has delivered more than 5 babies. So if the women is keep on conceiving and keep on delivering the baby, the uterine musculature of that woman might be disturbed, and the tonicity of the uterus might be altered or impaired, due to which the woman may land into uterine atony, which may indirectly cause postpartum hemorrhage. Then the second condition is over distension of the uterus, that is enlarged size of the uterus or more overextended uterus, which is seen in conditions such as polyhydramnios, multiple gestation, where the product of conception inside the uterus cause the distension of the uterus, due to which there might be atonicity of the uterus. Then antepartum hemorrhage. Antepartum hemorrhage is bleeding in the antepartum period, which occur after the 28th week of the gestation. The two main conditions that can come under antepartum hemorrhage are placenta previa and abruptio placenta. So if any woman has a history of antepartum hemorrhage, then she may be at a risk to develop postpartum hemorrhage later. Then history of prolonged labor and augmented labor by oxytocin. If any labor is induced or augmented with the help of oxytocin, in such conditions the infusion of oxytocin should be continued up to 1 hour even after the delivery of the baby. And malformations of the uterus, that is congenital anomalies in the uterus, which may lead to atonicity of the uterus and in turn into postpartum hemorrhage. Then uterine fibroids, if there are any fibroids growing inside the uterus, it may disturb the musculature of the uterus, which may cause atonicity of the uterus and precipitate labor and mismanaged third stage of labor. Now mismanaged third stage of labor, see, in third stage of labor we have to do the process very carefully. Like, we should not pull that cord, and we should not try to expel the placenta outside. First thing we have to do is we should see whether the placenta is expelled naturally or not. If at all we have to perform any cord traction procedures, we have to perform it carefully under observation and with all the safety protocols, because there may be a chance of rupture of any slight blood vessels, or there may be a chance that the placenta while pulling out may be damaged, and any bits of the placenta may stay inside, which may cause postpartum hemorrhage or continuous excessive bleeding. Then the second one is tissue. Tissue refers to any tissue which is stayed inside the uterus even after the delivery, such as retained placenta. Retained placenta is a condition where even after excessive normal uterine contractions, the placenta is not expelled out, it is staying inside even after the contractions. So such condition we call it as retained placenta, where the placenta is still inside of the uterus, it is not expelled out. Then incomplete placental delivery. Now incomplete placental delivery means, once the placenta is delivered, the person who has conducted the delivery should examine the placenta whether the placenta is completely expelled out or not. Sometimes what happens, some part the placenta may be damaged, and some part of the placenta or some bits of the placenta, it stay inside the uterus, and some of the placenta might be expelled out. In such cases, so the bits of the placenta which stayed inside the uterus may cause continuous hemorrhage, and the person may develop postpartum hemorrhage. So we have to examine the placenta whether it is complete or incomplete. Then trauma. So while performing episiotomy, we have to be very careful that we should not damage any major vessels that may bleed and develop postpartum hemorrhage, and we have to check whether there are any cervical, vaginal or perineal laceration which may contribute for bleeding. Then thrombin refers to any blood disorders the woman or the pregnant mother had. If the pregnant mother has any coagulopathies or any inherited clotting disorders, then in that case also the mother may have a risk to develop postpartum hemorrhage after the delivery. Then talking about the clinical features, see, from the starting of the video, we are saying postpartum hemorrhage, vaginal bleeding, postpartum hemorrhage, vaginal bleeding. So you may easily remember the first clinical feature, that is bleeding per vagina. The bleeding is very excessive, in very excessive amount, that is equal to or more than 500 ml, and the bleeding is also associated with pain. Then pain, and we may also see swelling in the perineal region and pain in the perineal region. And then we also see tachycardia, weakness and restlessness. As there is continuous bleeding, the mother may land into weakness, and there may be a chance to develop hypotension. The skin of the mother may be cold and clammy, and the uterus may be flabby. Flabby uterus in the sense the uterus may be enlarged, the uterus may be soft, and it may be tender. Tender in the sense when you palpate the uterus, the mother may feel pain in the uterus. So that is flabby uterus. Then when we talk about prevention, prevention is dealt or prevention is discussed under two categories, that is prevention in antenatal period and prevention in intranatal period. Antenatal period means when mother is pregnant, and intranatal period means when the mother is in labor or when the mother is having her delivery. So the first point which we discuss in antenatal period of prevention is we have to improve the health status of the mother. We have to educate her to eat properly, a healthy diet, well balanced diet, so that health status is maintained. And we have to also improve her nutritional status by asking her to eat all the healthy foods. And we have to also see that her hemoglobin level is not less. We have to maintain her hemoglobin level, because in further if there is any chance of bleeding, so that the mother can withstand some amount of bleeding, uh, like now if the hemoglobin level of the women is less, if there is some amount of bleeding, there may be a chance the women may land into silent shock. So in order to prevent all these complications, we have to maintain the hemoglobin level of the women in antenatal period. The second thing is we have to screen out the high risk patients. Now what are high risk patients? High risk patients are those patients who have conditions such as polyhydramnios, multiple gestation, history of postpartum hemorrhage, history of antepartum hemorrhage, the women who are gram multiparous, and women with severe anemia, because all these conditions may directly or indirectly lead to postpartum hemorrhage. So women with certain conditions must be priorly detected and screened out, and the delivery of the such kind of women must be done in well equipped hospital, so that if there is any risk of postpartum hemorrhage occurs, we should be ready to deal with that. Then we have to do placental localization, that is we have to locate the site of the placenta where it is implanted, to check whether it is implanted normally or it is morbidly adherent. Morbidly adherent in the sense it is implanted very deeply, that its separation, that it is causing difficulty for its separation. This morbid adherent of placenta is seen in conditions such as placenta accreta and placenta percreta, where the trophoblastic villi of the placenta is deeply invaded into the uterus up to the myometrial layer, in order to draw the nutrition from the uterine cavity for the growing fetus. If the placenta is very deeply invaded while the delivery of the placenta, it is difficult to be separated from the uterine cavity and expelled out. So in such cases also, the women may have chance to develop postpartum hemorrhage. So in the antenatal period, with the help of ultrasonography or MRI, we have to locate the place of the placenta where it is implanted. Then in intranatal period, obviously, as I have told you, the third stage of labor is managed actively. We should not follow any harmful techniques during the third stage of the labor. And if the labor is augmented or induced with the help of oxytocin, we have to continue the oxytocin infusion at least up to 1 hour even after the delivery of the baby, so that the contractions are continuous and the products of conception are completely expelled out and there are no bits of products of conception staying inside, right? So next thing we have to do in intranatal period is we have to explore the uterine vaginal cavity. Then we have to see whether if there is any trauma has occurred inside the uterus or inside the vagina. If in case if there is any trauma, we have to manage the trauma. Then we have to completely examine the placenta for its intactness. We have to see whether the placenta which is expelled out is completely whether it is complete or it is damaged. If damaged, we have to say whether any part of the placenta still inside the uterus. Then in such condition we have to curettage the uterus. So in this video we have discussed up to prevention of the primary postpartum hemorrhage. In next video we will see management of primary postpartum hemorrhage, and we will also discuss about secondary postpartum hemorrhage in detail. I hope you all might have understood the concept till here and you might have liked the video. If in that case, please like, share and subscribe to get updates about more such interesting videos. Thank you.